So I am Dr. Sengotuvelu from Apollo Hospitals, Chennai. So we are happy to participate in this live case. So I have my colleague Dr. Sendil with me, and we have a team anesthetist Dr. Ganapati, and I have senior technicians Andrew and Anu is a sister. So today we're going to show you the interesting case of a bicuspid valve TAVI. This is a 74-year-old gentleman, a known diabetic. He's been diagnosed to have severe aortic stenosis for the past 6 months, and he's been symptomatic, and he had repeated episodes of syncope. That was his presenting symptom, and now he's come for further management. So if you assess his STS score was 4.5, comes in intermediate risk. His Euro score 2 was 1.28%. And the frailty score was 4/17, which means he's quite not frail, and he's been quite active. So this is fairly well-built gentleman. Here the ECG shows, you can see the ECG. There are two things which we should look at. There's no conduction abnormality, there's no bundle branch block, no PR interval is normal. So very clear, this isn't predisposed to increased risk for conduction disturbances. Next, the echo. You can see the aortic valve is calcified, quite significant calcium. We can see a chunk of calcium with a mild aortic regurgitation. The mean gradient by echo is 54 and the peak gradient is 92. He has a normal LV systolic function. And coronary angiogram showed a single vessel disease, borderline LAD and diagonal, which we plan to manage medically. Next slide. So this is the pre-procedure MSCT. So you can see that here we have to see the coronary heights are normal. The aortic annulus is 22.3. The LVOT is almost similar to the annulus size. The sinuses are quite wide, about 30, 32. And both the left and the right coronaries are adequate. And the other thing to note is the ascending aorta, which is dilated. Let's have more details. Next slide. So if you look at the annulus, again, there is annulus, at least in this short axis, doesn't have much of calcification. There's much calcium not extending into the left ventricular outflow tract. Next. So this is a bicuspid valve. You can see the fusion of the left and the right cusp, which is most common type of bicuspid valve. Not only in the Western data, even in India, which we have shown in our own study. And you can see there is the raphe between the left and the right. There's not much of calcium in the raphe. The ascending aorta is dilated. The average diameter is 42.3. So that is again should be taken into consideration that it is less than 45. So still he qualifies for a percutaneous procedure. We'll discuss that more. Next slide. The sinotubular junction is adequate. You can see the left and the right coronary heights, which are quite high, and we don't have a higher risk of coronary obstruction because of the higher levels of coronaries as well as large sinuses. Next slide. So the calcium is obviously very high. You can see the heavily calcified valve leaflets, and there is calcium at the sinotubular junction, mild calcium, and also coronaries are calcified. The coronary calcium score of the aortic valve is 1200, which qualifies to a severe calcification. And next, please. And you can see the LV aorta angle. You can see the S curve. The S curve looks more of a vertical S curve, which means vertical aorta. It's not a horizontal aorta, so probably the crossing would be less difficult. Next slide. And again, you can see that bicuspid valve. Next slide. This is to look at the origin of the coronaries and for commissural alignment. But here, I think in bicuspid valve, we don't worry much about because there are only two commissures. Next slide. So the iliacs and the femorals are quite adequate. You can see there are the points to note in this is the size, which is the femorals are above 6.9. And the iliacs against above 6, and the aorta, there's not much. Second point is not much of calcium in the peripheral arteries. And number 3 is some minimal tortuosity. There is not much of tortuosity. And additionally, we also look at the bifurcation. Here you can see the right bifurcation is quite low below the femoral head, which is clearly a good option for femoral puncture, whereas on the left side, the bifurcation is slightly high. So we measure the length of the bifurcation from the femoral head, and at least we want it 2.5 above the bifurcation. This is to make sure that we don't have if you have any issue, we don't want to lose the branches in case of a need of a covered stent. So now with this, the next slide. So with this, what do we do now? Next, based on sizing. So I want to discuss on the valve type, the sizing. So here, in a bicuspid valve, there are a number of methods to size the valve. This is based on Bavard registry. The intercommissional distance in this patient is 26.2, and the annulus is 22.2. So based on the Bavard registry, it's a flare type, which means the annulus is 22.2, so which is tapering at the annulus and is flaring at the level of the supraaortic area. So based on that, we will now go with the smallest dimension, which is based on the annulus. So we will make a strategy based on the annulus. Also in the consensus data now with various methods like Lira method, Casper method, as well as circle method, which is recently very popular. The consensus is to use most of the time the annulus diameter for choosing the valve in bicuspid valve, but because majority, about 80 to 90%, where the annulus is the narrowest point in a bicuspid valve. And also, reducing the size really doesn't affect the long-term outcome of these patients. So based on all this, our strategy is to elderly man, to summarize, is an elderly man with intermediate risk for surgery, has severe symptomatic aortic stenosis, has a bicuspid valve type 1A, and a flare type based on Bavard registry with a heavy calcium score of about 1100, and no significant coronary disease with a good peripheral access. So let me stop with this next slide. So do you want to discuss a little bit more before I go further?
Sir, I think we can get the case started while I will take opinion from my panelist about the case details that you have discussed.
Okay. No, I would feel that what the panelists think on the choice of the valve before I comment on what I'm going to do, strategy, what would be the sizing and all that. If they all agree with my views, then I can proceed. Just can I have a quick discussion?
Sure. Sir, I think we can go ahead. We can proceed with the procedure.
Okay. Okay, no problem. Okay, based on this, the ascending aorta is less than 45, so I'm not worried about this. Okay, going into the TAVI, next slide. So TAVI, again, what choice? Again, choice here is a balloon expandable valve. We plan to use a Merrill My valve, considering that this has a better radial strength and we will have a good circular deployment because of extensive calcium, and also the chances of PVL may be much lower, and the pacemaker risk also may be lower in such a difficult anatomy with heavy calcium throughout. Next slide. So our sizing rationale is we want to size it. Normally we size about 10 to 15%, bicuspid valve maybe 0 to 10%, and you are heavy calcium. So based on the area of 394, we would choose a 23 millimeter My valve, which is approximately about 5.5% oversizing, which is reasonable. Maybe we can even add an ml, and according to how we feel, we can decide on how much volume to expand the balloon. Next slide. So plan is using conscious sedation, no transesophageal echo, no urinary catheter, ultrasound guided access, and with femoral access, transfemoral access, pre-dilatation because it's heavily calcified bicuspid valve, and plan to use a 23 millimeter My valve. And we always use a hybrid closure with both one ProGlide and one angioseal with suture and a plug-based device. Next slide. So quickly, I'll show you. We have presented for the first time a 2-year follow-up of our experience from bicuspid valve, which is published recently along with Dr. Ashok Sheth. We presented this data. Next year, next slide. We have a very good success was 98.2. Next slide. We have good follow-up of these patients. I'll just show the last slide. Next slide. So we can see that up to 2 years, you can see the valve area and the post-procedural follow-up are extremely good. The patients are doing well at 2 years. Next slide. So this is a real-world Indian experience. The first data, up to 2 years, we have data in bicuspid valve, the patient population, which are quite similar, similar to across the world, which means type 1A, which is the most common type of bicuspid in India. And these patients do well with TAVI. Thank you. Let me now start the procedure. Can you show the, we've already taken the puncture. Let me show the ultrasound here. Can you show the ultrasound? So normally we use ultrasound guided puncture. No, the previous one, please. I use both the longitudinal as well as short axis. You look at the previous one. You can look at this. You can see the femoral head. I hope you can appreciate that. And you can see the bifurcation. And above that, you can see the femoral artery. There is a chunk of calcified plaque just at the posterior part of the artery. So that is, can be avoided. The puncture can be obtained a little more higher. And next slide. Now we move to the short axis. From the long axis, we move to the short axis. And you can see the calcium, which is posterior. Next, so we usually give local, you can see the local being infused at the top of the artery. So we use ultrasound and give a infused local here. And next, and then we puncture. You can see that the needle coming from above. And play that. So you can see the needle coming from above and the needle going inside. You can see the needle going inside the artery, which is clearly seen. And then we puncture, next slide. We puncture also the left side, and you heard a little bit above the bifurcation. You can see the wire going across femoral artery. So we punctured using ultrasound. Next, you can show the fluoro. What we have after that, we always confirm with the fluoroscopy. Can I have the fluoroscopic image here? Yeah, play that. So we see that it's a puncture is just to confirm that the femoral puncture is exactly on the femoral head. And next slide. So this is the coplanar view, which derived by CT. We modified it a little bit. And this is the angle RAO4 and caudal 24. Go back, please. This is the view which is coplanar. You can see all the three cusps. We have kept the pigtail in the right coronary sinus. And you can see, though the left side, the non-coronary side is filling less, we can see all the three cusps in one plane. And next slide. And you can see both the coronaries filling well. Next. So this is now we shift the pigtail from the right sinus to the non-coronary sinus. Non-coronary sinus is the lowermost part of the sinuses, and we want to keep the pigtail to serve as a landmark for the annulus. Next slide. So based on that, now we have just crossed the valve. We have taken a Python sheath, and with using a stiff wire, we put a Python sheath, and then put in a AL1 using a Teflon wire. We were able to cross. Sometimes these aortic valve may be sometimes challenging because of the heavy calcium with the bicuspid valve. But here it was it just took hardly less than a minute. We were able to cross it. And this is where we are now. We have put a pigtail. So we are going to show you now live from here. So you can see the gradient. Can you show the gradient now quickly? Can you connect this to the pressure line and show the gradient? So can you show the hemodynamic monitor? We will show you a. So can you see that the gradient is almost about 70 millimeters of gradient?
Yes, sir, we can see the hemodynamics.
Okay. Great. Now I'm just taking it out. The pigtail is in the apex. Can you show the apex, please? Can you see the fluoro now? So it's important to put the pigtail in the apex, and it's important to make sure the pigtail is free from the chordae. It's also important to face the ring of the pigtail above. It's all important, and making sure the other pigtail is in the non-coronary sinus. Also, we are sure that the pacemaker lead is properly placed and we have good pacing. Now we are taking a safari wire. This is small size safari, extra small safari wire. Most of the time we use extra small safari in these patients because most of our patients have a small ventricle. So I would prefer to use an extra small wire. You can see that while I'm taking the wire inside the ventricle. And
sir, may I request your IT to get the fluoro screen bigger so that we can see it slightly better?
So I'm taking in a 18 millimeter balloon. Here the annulus minimum diameter is 18, so 19. So I'm just taking 18.3. So I'm taking 18 millimeter balloon. So I'll do a pre-dilatation, about to cross it. Can you show that in the small screen? They want to see also the hand movements. I hope you can show that in a small insert. Okay, are you seeing now both?
Yes, sir, we are able to see your hand movement, and we are able to see the fluoro screen both very clearly.
Okay, great. See, now I have put the balloon now. I'm going to put the balloon a little more inside. So we are ready to go ahead and inflate the balloon. Look, pacing on, please. Also, the hemodynamic monitor, if you show them, no? Pacing on. Okay, the pressure has dropped.
Maybe we can see the hemodynamic monitor as well.
Deflate. Okay, pacing off. So we will pull the balloon a little bit back. Okay, the pressures come up a little bit. Can you show the hemodynamics also to them?
The ECG and the hemodynamics.
Okay, pace, please, pacing. Pacing, please, move. We'll take it out. Give some time for them to come out. Let them come out. Get the pressures up, please. Yeah.
Get the pacing.
Can you get the pacing, please? So also show them the hemodynamics, please. So you don't have to show me. If you can show them the insert of the hemodynamics. Yes. Show that. So we'll wait some time, let the pressure come up, and then we will go ahead again.
Show the one screen also, no?
How is the echo? Okay, great. So Ganapati,
Sir, are you still pacing?
Yeah, because he had a Brady, so we are pacing a little bit. Yeah, just reduce the pacing rate and see. He's pacing because. Let the pressure come up. The wire is free from the mitral apparatus. See, Ganapati.
The pressure is picking up now.
Yeah, that looking good. Yeah, so okay, can reduce the pacing and see if he's still dependent. Okay. Okay, I think, shall we go in for again a balloon dilatation? Ganapati? Ectopics may because of the wire. It's okay. Yeah, fine. Okay, let's go and dilate again now. Hold the wire. Let me cross. Okay, that's fine. Okay, pacing on. Can you pace on, please, Ganapati? Okay, pressure is down. Inflate. Okay, that's good. Okay, deflate. Okay, pacing off. Get the balloon out. Pressures are coming up. So get the balloon out.
But it is okay.
Yeah. So remove the balloon. Send the weight. Yeah, take it out. So we normally don't inject during balloon inflation, but sometimes when you have difficulty in sizing, when you have a higher risk of coronary occlusion, then we always do a contrast injection during balloon inflation. In this case, I think we are quite happy. And show me the balloon inflation again. So you see that play. So you can see that actually there is not much of waste. Even there is a small waste which is only at the annular level, just above the annulus. It's not at the supraannular level. So let us now go with the valve. Can you show the hand again, please? So this is a 23 millimeter my valve. Most likely we'll go adequate with the nominal volume. We will not go much.
So do you routinely dilate the sheath before going in?
We don't. We sometimes do it. That's a good question, particularly when you use a large valve. This is might sometimes be very difficult to push in this valve. So we will use, see this is only a 23 valve, so I don't like, and the large artery is also reasonably big. Can you show now the groin, please? So with this groin, I don't routinely do it.
Right. So the Python expandable sheath, sometimes when we take a larger valve,
keep it straight.
The force required to push is very high. So sometimes we take an 18 French dilator and just dilate the sheath.
Absolutely. See how this valve goes
before
in?
We take the valve.
Okay, now we can go show both the valve and the wire. Both the wire and the valve. Python sheath at least, yeah. Keep it low. Show the wire. Right. Let me come out of the pipe.
So in this case, the valve size is only 23 millimeters, so probably we can get by without dilating the sheath. It doesn't hurt. It's just that you have to apply a lot of pressure for the valve to go.
the pigtail has come out. See, the important aspect is that's an important point what you said. So let us, now we've taken the valve in. Now what we're going to do is to make sure the pigtail is in proper position. That's the most important step before we deploy the valve. So let us get the pigtail in. So pigtail, you can see it doesn't move. So what we should need is a wire. Now come, give me a wire please for the pigtail.
And sir, your midpoint of the balloon
So
is
the
slightly asymmetrical from the valve, so probably should be looking at the valve for deployment rather
so
than
we
the
should
midpoint.
Exactly. We, yeah, that's an important thing. We should always look into how it was loaded, particularly when they're crimping it. And
very
also
minor, but I
when
think
the
shouldn't
marker
get
should not be completely relay. I agree with you fully, yes. The other thing is with the wire in. It goes to the right sinus. It has got a tendency to go to the right sinus even earlier, so the valve is not actually affecting the movement of the pigtail, so it goes to the right sinus again. I think it's still in the right sinus. We can check.
Do you think the device is not allowing the thing to go that side, to the left side, to the NCC?
We can get it back a little bit. I don't think it is, but I can pull the device back a little bit. But that is not the reason. But anyway, no, even earlier, when I put the pigtail, I was not able to get into the non-coronary sinus.
Yes.
Okay.
Perfect, you
Connected.
got it.
Yeah. Okay. So the three things which we need to do, one is the pigtail position. The second is a connection. Before we inflate, make sure all the connections are right, adequate volume.
Sir, can we check your anticoagulation strategy for these patients? How much heparin? When do you check ACT?
Pigtail again, it's come out. So when you move the device, okay, it's fine. Okay. And normally keep the ACT around 300. See, the pigtail actually said, as you said, it's interfering. When we move the valve, it just
I think
moves
just
out.
pull it back
Okay.
proximal
Okay.
to the arch and then deliver it again.
Yes. Fine, fine. Let us go in. Now we are okay. Okay. Let's cross the valve now. So pacing also we need to check. Pacing is good. So let's move inside. We'll cross. So we've crossed it, gone deep a little bit. Okay. Pigtail again is moved up. Give me wire again. The pigtail doesn't listen to what we do. See?
Wire. Valve is across the wall.
Well, doesn't matter. The patient, the hemodynamics are okay, so we don't have to rush or anything.
So sir, while you position your pigtail, maybe I'll ask my panelist about your case. So bicuspid valve with ascending aortic aneurysm, 42 millimeters.
Can I contrast, please?
What is the thought? I'll just ask Ajay sir and rest of the panelists. Maybe Ajay sir and then Khanna sir, we can probably
small
ask.
test.
Ascending aortic aneurysm, bicuspid aortic valve.
So I think it's not an easy question to
position
answer.
looks good.
We are playing
Test.
off what we get right
Test.
now against what might be required for the future.
Test, please.
I think the cutoff of 45 that he has mentioned is extremely, very good yardstick. But if you have serial
Test.
follow-ups and you are showing that it is
Come
expanded
to the view,
more than
please, Andrew.
1.5 in 6 months,
View.
in that case, patient will be
Okay,
better off
picture.
with surgery because it's going
Test,
to
test.
expand
Are we
some
in the
more
left
very,
side
very
sinus
rapidly.
test?
And it will
We
expand
are
faster.
the
He'll require
pigtail is
surgery
not in
faster
position.
than
That's the
the
problem.
valve will
Give me
decline
wire
or
again.
deteriorate.
Test
So,
now.
but I think for this patient,
Test.
the choice is pretty good. as
Pigtail,
far
when
as
you inject it, moves. Problem is pigtail is
Khanna
not
sir,
at
your
all
opinion?
good position here.
This is not
If
an
you
aortic
inject
aneurysm, it's
also,
just
it
an
moves.
aortic dilatation.
Hold.
And I believe what he's doing is right, but suppose there was an aneurysm, the better thing would have been to do a Bental and finish this off.
Test.
So
See
do you
the
guys think that after aortic
arteries.
valve replacement, the rate of dilatation is going to slow down?
I definitely think so,
No, it's
because
good.
this
Picture.
is a post-stenotic dilation, and it's because of the eccentric jet
I want
which
you
is
to
hitting
come.
on the
Want somebody
ascending
to hold the
aorta.
pigtail. It's not very stable. Sister, hold the wire.
Agree, in case it's
Just hold the
moderate
pigtail.
aortic
It's very
regurgitation,
unstable
in
it
that
is.
case,
Okay.
putting a valve in actually changes.
Yeah, we
But
will.
most of the time, it's an arteriopathy in patients with bicuspid aortic valve. There's not much evidence that putting in a
Okay,
valve will
test and
change the
handle.
rate of dilatation. If you have a 50 or a 55, I think there's no question.
Okay, picture.
whatever
No,
one wants to
pigtail is
call it.
moved again. Leave it. Keep it like. No, leave it to me. Leave it to me. Leave it to me. Test. See, the problem is we are not getting the pigtail the lowermost point, and even if a slight injection, the pigtail moves.
Right.
Okay, picture. I think we need to withdraw picture. So we are very well low, so you have to hold the pigtail like this without allowing it to rotate.
Right now, we can accept your pigtail position.
See
I
the
think the valve just needs to be at the right.
No, okay, test please, Andrew. I think this is good because a pigtail is not the best position, doesn't matter. Okay, let's not go very much, only the pigtail. Ready, picture?
So right now, you
Maybe
seem to
pull
be
back a
in a
millimeter.
good
I think looks
position.
okay. Picture? Yeah, not too bad. Actually, I can
Not
pull a
bad,
millimeter up. What do you all think?
I think this looks good.
Maybe
I
a
think this is
millimeter up.
absolutely
What do you-
fine.
Huh?
I think it's good, provided you maintain it while deployment.
No, I would probably
Secretary,
prefer
you
a
can
little bit
actually
up
start
because you still
pacing.
will get.
You
Yeah.
can pace, inject,
Yeah,
and
we can
then
do that.
decide
We
whether
can
to
do that.
deploy
But
or not.
can you hold this here? Please don't allow it to rotate. Let me pull a millimeter back. Okay. Remember the two dark bands? We want to keep it in the middle of the dark band. Next picture, please. So don't go by the marker. We are going by the second bigger dark band. We want the middle of the dark band.
Correct.
So we can pull it up a little more than this. Yes. Okay, I want to pull it back a little more. See, I don't mind having a 90-10 or even a 0-100. Okay. See, when I pull back so much, I don't want the torque to be released later on. So I always want to pull it and push it back again. Okay, picture. I think now it's okay. I think we'll go and pace and see. Okay. Hold this. Okay, pacing on. Okay. Pacing on. Okay. Inject, Andrew. Yeah, wait till you. Okay. Go up. Leave it, Sindhil. Go up slowly. Go. Go. Full, yeah. Okay.
1,000, 2,000, 3,000.
Okay, deflate. Yeah, deflate fully.
Deflate, sir.
Okay, now spacing off.
Facing off.
Okay, pacing off.
Okay.
Okay, back pressure, please. Yeah.
Yes.
Okay, can you show that deployment? Pressures are getting better. So can you show the deployment? So we almost looks like we've got a 90, 10 or even 100, 0. So pressures are slowly coming. Can you get the pressure up, Ganapati? Oh, pressures are okay. Collection, no collections. Echo is good. Okay, good. Get the pressure up.
Can treat the pressures.
You want to pace sometime?
No, I
Rate
think
is
just
good.
treat the
It
pressures.
looks like
a
it's
little
a junctional rhythm. Yeah, that's what. Yeah.
Now with some inotropes.
What we will do is we are starting. We have a fantastic anesthetist here with us, Dr. Ganapati. So I think he's on his job. So we'll get it up. Is it okay, Ganapati? Yes. So I think the rhythm is looking like junctional to me. Maybe that is probably not giving the pressures a little bit.
Yeah, we just need to get the pressure resuscitated.
Yeah. Can you give some inotropes, please? Yeah. Can you take the valve out? Put the valve out. Get the pressures up. We need to, should we? Do you want a massage?
So you want to take
Okay,
a
take it out, take
pigtail
it out.
shot just to
Okay,
make
okay,
sure everything is okay?
No, it says contractions. We are going to do that. We're going to do that. That's what we're going to do that. Come.
Yeah.
We're going to do that quickly.
Root aortogram. Pressures
pull
are
it
coming up slightly.
Yeah, we do that. Come. Ready. Yeah, ready. Picture. Diagram. Ready. Ready. The coronaries are good. There's no.
Yeah.
Oh, good. So,
Sir, your valve looks perfectly fine. I don't see any problem there.
yeah.
Seems to be
Yeah,
a little bit
yeah.
of paravalvular leak.
Yeah.
Hey, it's
Little bit
come
of a
up.
leak, isn't
Yeah.
there?
Yes, that's
A
about
little
it.
bit of leak. Yeah.
Here
yeah,
you go. Your
yeah,
pressures
yeah.
are pretty good now.
Pressures are coming up now.
Yeah. So let us get the pressure at level and then assess the for the aortic leak and then see whether we need to do something more. We took the wire out. We can always wire it back. Put a pigtail. See, when we have any to when by chance if we need to massage or anything, it's always important to remove the LV wire, and otherwise it can lacerate the LV. So,
It's a great point.
so here I think we didn't have to do that. Actually, the rhythm now is sinus. Probably for transiently, he had a junctional rhythm, and maybe that was also causing a bit of hypotension.
Dr.
Can keep
Sangeeta
going
Valu,
straight.
this is Dr. Khanna. So as a protocol, do you keep your
Hi, Dr. Khanna.
inotropes? Do you keep your inotropes on board and just push them as you do it in carotids, or you wait for the rhythm and the contractility to, come back and the pressures to come back on their own?
No. We start. We don't. We allow it some time, but we get a transiently. We have to immediately start inotropes if we have this longer hypotension. We don't see this is very frequently. We don't see such long hypotension, but then otherwise we probably start.
But it's a good idea to keep
up,
the
send- show up,
vasopressors
please.
mixed and ready.
On board, like we do it
and
in
attached.
carotids.
You
And
just don't have to start it,
absolutely.
but keep
Yeah,
it
yeah.
ready.
We always do that. Our cath lab always has that ready. Yeah.
We actually have 50 micrograms of
Sure.
phenylephrine and epinephrine, the kind of ready loaded in syringes, in case if we need aliquots of that.
Yeah.
Correct. Absolutely. Right. So a suggestion of continuing 0.1 ml per hour just for the
Any AR and echo?
good luck part of it.
No? No AR, so then I don't think we're going to cross now. Let us check the echo. Show the echo, please. There's no AR, so I think we will redo a. Huh?
Your valve looks
Why,
perfectly
no wire,
fine.
nothing is there. Let us do another itogram now. Come, ready for another itogram? Why everything is removed now? Come, can you remove the parallax a little bit? Come caudal. Let's do the another.
So can you increase the contrast volume so we get
yeah, contrast volume we can increase, Andrew, increase it to 15 ml. So the mean gradient is 6. Mean gradient is 6 millimeters mercury. Peak gradient is 13. So 13 and 6. I think
Perfect.
that's a fantastic
Absolutely.
single-digit gradient, which we can accept. So let us see if there is no leak. I think that there are no conduction systems are normal. There is no any disturbances. So ready? Okay, inject. Yes, it's good. It's very good now. So, what do you think?
So trivial leak, almost 80-20, bordering 90-10 position. Both the
Absolutely.
coronaries are looking
Yes.
fine.
Yes.
Your gradient is excellent.
Yeah.
This is as good as it can get.
Yes. So I think we are happy with this. I think let's now close the groin. Yeah. Put.
This case also
Yeah.
gives that suggestion that your valve was about 5% oversized. So in severe calcific cases, a 4-5% oversize is absolutely fine we don't really have to go to 8-10%, which
Yeah.
typically what we used to do before. Typically, there is no paravalvular leak. You get a very good gradient and minimize the risk of annular injury at all. So at 5% oversize, your valve is
Show
functioning
down.
absolutely well.
Show down.
Excellent demonstration.
Show the pigtail. Show the pigtail. Where is the wire? Malakami, Andrew. Show the wire tip. Okay, okay. Leave it like that. Wait. Show up, please, Andrew. So always important to put a sheath inside before we remove the sheath. Keep the dilator inside. Give the dilator, please.
Sir,
So
one
the other
question
thing
is
I
how
told you
often we
that
get
we always
annular
do one-
injury? Dr. Sangatuvellu, could you share any of your experience,
Yeah,
any of your
yeah.
patient where you had annular injury?
So I think I think out of our 250 cases, we probably had one angular injury, but fortunately we were able to contain rupture. We didn't do anything, and patient did well without a problem. Otherwise, we didn't have. See, the sizing is critical, and sizing again depends upon number of factors: the amount of calcium, distribution of calcium. If you have a calcium in the LVOT, then we don't want to oversize the valve. We could just even go sometimes zero, even 0% oversizing or 1%, less than 5% oversizing. So it's again, if you size the valve well, and if you have such amount of calcium, embolization risk is almost negligible or zero. So we don't worry about that. So I think it's all the sizing. So I don't think there is a big risk for annular rupture. But
So
again, the location of the calcium is what really determines what annular rupture.
Ajay, sir,
Give
you
me
have
a
something
bit
to add?
cost. So can you show down, please? So I'm going to show you how we do a single proglide. See, I have deployed a single proglide in a 12 o'clock position again. So when we do a single proglide, we always use in 12 o'clock. And now we will remove the sheath with the dilator. And most likely, it will stop. If it doesn't stop, we will put one angioseal. Go ahead. Can you show it nicely, please? Can you see that? Yeah.
Sir, do you give
See, the
heparin
bleeding is
reversal?
almost
That
stopped.
is one of the question.
Yes. We give 50% heparin, we reverse, not completely. Routinely, we reverse 50%. See now, with one proglide, it's stopped, bleeding is stopped almost, but there is some mild ooze, which we will observe for some time. And when we reverse the heparin, this should go away. If not, then we will put another angioseal. So I'm not going to take the wire out, because this is important for me for angioseal if needed. So I'm secured the wire. Now I'm going to tighten the proglide.
So you'd like to take a shot of the iliacs before, one shot of the iliac from the opposite side?
Yeah. Yes. Yeah. See, I will show it to you, but nowadays we have stopped that also. We are just doing a Doppler. You go ahead, please show the iliacs. We'll take an injection from the pigtail. We were doing that earlier, but nowadays to reduce the contrast load. But here this patient is not a problem with the contrast, so we can do it.
So sometimes the python sheath, especially if there's a little bit of calcium, can leave something behind, and then we have to come back and do something about it.
Absolutely, I agree, Doctor. Absolutely, it's important to
This
see
is
that
Dr.
we
Swami
don't
here,
have
Dr.
any issues with the groin.
Ajay Swami here.
How are you? Good to talk to you. Okay, let's do a itogram. Can you do a?
I think the proglide
Andrew,
looks
can you
good. There's no
show- I
pulsatile
want
flow,
to
so
show
if you
from
reverse the heparin, it should be fine.
Yeah, that's what I'm going to do. I'm not going to put an angioseal. Exactly, I agree with you. So I'm going to remove the wire. So remove wire. So I will just reverse the heparin. Okay, ready? Yeah, half reverse heparin, half reversal. Ready for injection? Okay. Yeah, a little bit more. I'm going to come down. Okay, see, I can see the aorta also distally. Ready? So, Dr. Ajay.
Looks very nice, sir. No problem.
Dr. Ajay Swami, you happy? Okay, great.
Yeah, I'm here. Please go ahead.
Put the wire. Okay. So it's actually stopped completely. You can show this here.
Yeah.
Yeah, protamin. Still, protamin is just going to be given. Before that, it's completely almost stopped. So this with one ProGlide. So this we have been doing consistently using only one ProGlide. One of the big advantages of using one ProGlide is we don't see the stenosis. When we use two ProGlides, occasionally we were seeing femoral artery stenosis. But almost now it's completely not there. I can just show this. So we will suture this skin wounds. So to summarize, I think now we can show us. So in the key learnings from this case, I think in a bicuspid anatomy, one should assess the CT carefully. Here the peripheral arteries were quite okay. We didn't have much calcium or tortuosity. Here the challenge was it's a bicuspid valve. The calcium was heavy. So choosing the size of the valve is again very important. Choosing where to size the valve in bicuspid. Here we choose the annulus sizing. And then a balloon expandable valve here, because of calcium load, always a balloon expandable valve gives a high radial strength. So we will be able to see the calcium expansion and echo. Echo, you can show the circularity and the gradient. Can you show echo also? We'll show you that. How circular in the short axis, we can show you that. We can show the echo live. So again, the circularity is very important because the valve coaptation is much better, and the long run, the leaflet thrombosis as well as leaflet degeneration is much lower when we have this kind of a, can you show the valve in short axis so that we can, yeah, no, record, now live you show now. Don't show the recording, yeah. Show it now. A post deployment, I want to see. So that is again, we can show it to you now. So you can see that valve is circular. I think we are talking more about the ellipticity index, and that is related to long-term outcomes. So we have here a very recent, it's quite circular. Oh, and if we can also carefully appreciate also a little bit of the left coronary, and the commissural post also we can see here a little bit. So I think the other thing is to, once you plan it meticulously with the CT, I think the execution is much easier. I think we got very good result in terms of the gradient, no parallel leak, and the local closure is again done with one ProGlide, which is quite useful to reduce both the cost as well as to complication related to stenosis. So thank you, and I'm happy to answer your questions.
Thank you so much, sir. I think that was an excellent demonstration of the case, complex bicuspid valve, nicely demonstrated, an excellent result. Thank you, Dr. Sengotuvelu and your team for that excellent demonstration.
Thank you, Dr. Rath and Dr. Manoj for this wonderful meeting, and it's really enjoyable. I think I couldn't miss the coming to Hyderabad. Hope to see you next year. Thank you.